Hello everyone, this is an audio review for quiz number 7, which covers chapter 8 and chapter 17. So let's start with chapter 8, which is, topic is pain. Okay. So when we talk about pain, remember we need to kind of understand the physiology of pain. It is sensory experiences, emotions, cognition, in turn within the concept of time and space. Remember, we have afferent passageways which transmit impulses, messages to the brain for interpretation, and then efferent, which carries messages away from the brain as a response. Remember, there are receptors that activate those afferent pathways. We refer to those as nociceptors. Okay. Remember, we talked about, especially when we talk about pain generally will be at the site of injury, but remember, pain can also be in a location other than the site of injury, and we refer to that as referred pain. Okay, and so that's because they share the nerve fibers have other locations where it may be stimulated in relationship to the injury. So an example is right shoulder pain with liver problems, left arm pain in relationship to chest pain. Okay. So remember, when we talk about pain, that it could also be in other sites. Other things to make sure you remember we talked about one theory in relationship to pain, the gait control theory. Remember, that incorporates the physical and the psychosocial components that contribute to pain. So just remember that pain is transmitted, painful impulses are transmitted through small diameter nerve fibers in the afferent passageway. So that's transmitting those signals to the brain, okay, for interpretation. When these fibers are stimulated, it allows that transmission. So those small fibers, when stimulated, allows transmission. Just remember that gate can open, relationship to tissue damage, relationship to fear of pain, as well as environmental things, like monotonous environment, bored, okay? Now, to close that gate, or to close the transmission, it is the stimulation of large fibers that does this, okay? And it basically cuts off that transmission and decreases the perception of pain. So when we talk about pain, there's two ways the large nerve fibers can be stimulated, and that's through cutaneous stimulation or skin stimulation. Good examples that we could do this is, massage, changing position, hot and cold therapy. And then the other way we can close the gate and triggering those large diameter fibers is sensory input. So distraction, imagery, okay. Preparatory information for a procedure often helps. Okay. Remember, there are a lot of physical factors in association with pain. There are a couple of terms we need to make sure we understand. Pain threshold. Now remember, pain threshold is the point in which a person feels the sense of pain. In other words, to what extent is the pain stimulated, the intensity, essentially, to where they start to feel it, okay? Now, remember, pain threshold can change. It's not always consistent. A lot of factors play a role into this. So, pain threshold, just remember that pain threshold can decrease, okay? And so when we say decrease the threshold, that means pain is becoming more, they can sense it more easily. Okay, remember, their threshold's dropping, so they sense it more easily, versus if it goes up, if pain threshold increases, they are able to tolerate more before they feel it. Okay? Pain tolerance. And remember, this is kind of that end piece. When we talk about threshold, that's the bottom end. We start to feel it. Pain tolerance is the most a person can endure, okay? Age plays a piece into this, okay? Other things that play a role into this, it's fatigue, anxiety, insomnia, uncontrolled pain, okay? Prolonged pain as well. Other factors that play a piece into this is, the type of surgery and the anesthetic influences pain as well, so we need to kind of keep that in mind. Remember, autonomic nervous system plays a big piece in the body's response to pain. So remember, we have, the fight or flight response, right? Pain triggers it normally, okay? And so certain things are triggered. So think about, what changes. So you have your sympathetic nervous system. It's the one that turns everything up. So heart rate increase, respiratory rate increase, blood pressure increases. And then we have the parasympathetic system, kind of the counterweight. But the thing we usually see this in relationship to pain, is constipation and urinary retention. Okay. Remember, pain has a different response depending on the type of pain. Remember, acute versus chronic. Okay. Remember, acute pain is, we know what it is. It's treatable. It follows the normal nerve pathways from nociceptor triggering. We also usually refer to this as nociceptive pain. Okay, so it served a message, a purpose. So it is a warning that there's tissue damage, and when healing takes place, that it will stop. Okay. Remember, there are factors and signs. So you talk about behavioral, physiologic. So think about what somebody does when they're having pain. So this is acute pain, remember. So, guarding, rubbing the body part, kind of furrowed brow, wrinkles in the brow, kind of biting their lip, and then we talked about, heart rate, blood pressure, and respirations often go up. Okay. The other side of this acute pain is chronic pain. Remember, this is persistent pain that persists or reoccurs, and it lasts longer than 6 months. Oftentimes, it could last a lifetime. So you have to remember, chronic pain, it follows an abnormal pathway. It's not following the traditional pathway, and it's neuropathic pain. Okay, and it has to do with nerve damage, versus actual trauma to tissues. Okay, so this is where they will see their sensations will be a little different. It'll be burning, shooting pain, kind of abnormal sensations, but there's nothing that would indicate they should have pain. Okay, so examples, arthritis, cancer, peripheral vascular disease, traumatic injuries, old traumatic injuries in particular. Okay, so, let's talk a little bit about, acute and chronic pain kind of side by side. Okay, and so, we need to talk about this in terms of, let's start with, time. Acute, time, it's a limited, short duration in terms of how long they experience it. We talked about chronic being, can last 6 months or longer. We talked about purpose. So for acute, pain is a signal that there is tissue injury or damage, versus chronic, it doesn't serve any purpose. Verbal, somebody who has acute pain will often report it, and they tend to focus in on the pain, only think about the pain. With chronic, they usually don't report pain unless they're asked, okay, because they're so used to it. And then, of course, you got to remember behavior. So if it's acute pain, they're going to be restless. We talked about rubbing the body part, grimacing, and so on. But when somebody has chronic pain, they're not going to have those symptoms because they've been dealing with it for a long time. So they'll be tired looking, kind of lack minimal facial expression. They'll often be quiet. They'll sleep. Kind of redirect their attention to other things to distract themselves. Okay. And then the physiologic we talked about, acute is, heart rate, blood pressure, respiration goes up. In a chronic pain, usually the vital signs don't change because the body has kind of acclimated itself to it. Okay, let's talk about pharmacological and non-pharmacological interventions. We talked about hot and cold therapy. Remember cold therapy, we should not apply it for longer than 15 minutes, or we can end up with tissue trauma, basically frostbite. Heat is a maximum of 30 minutes. Okay, we could use those other kind of, I call it mental non-pharmacological, so guided imagery, relaxation, environment control, so adjusting the environment, temperature-wise, and so on, noises, those types of environment controls. Then massage can be very useful. And then TENS, that's the electrical nerve stimulators, often done for back pain. And remember, it's basically sending electric current to stimulate the skin and the tissue underneath. And we're not quite exactly sure how, but it decreases the intensity of pain. Okay, let's move on to pharmacological interventions. That's our drugs. Okay, so remember when we talk about pharmacological interventions, need to kind of remember a few things. The way it works is, they use the incremental types of drugs or stronger drugs depending on the severity of pain. So remember we talked about step one, those are non-opioids. NSAIDs are always the first choice. I'm sorry, not NSAIDs. Acetaminophen, Tylenol are always the first choice because they kind of generally tend not to have any side effects with use in general compared to like aspirin or NSAIDs where it can cause GI stomach irritation and potentially bleeding. Okay. Step two are opioids. This is for moderate pain. Okay, and so, examples of this is codeine, oxycodone. Okay, and if pain persists and it becomes more moderate to severe, this is where you use the stronger stuff, morphine, hydromorphone, methadone. Okay. Remember we talked about how chronic pain, oftentimes the opioids and NSAIDs don't work as well on chronic pain. And so they may use adjunct drugs. So, that's your tricyclic antidepressant, anti-seizure meds, caffeine, benzodiazepines, and stuff like that. Okay. Also remember, opioids can be given in several different routes. It can be done, given orally, through an intravenous IV, epidural. Okay. And we have to kind of remember that when we're giving pharmacological medication, that depending on the condition that's causing the pain or the predictability of pain, dictate the best way to administer in terms of frequency. So if it's predictable pain, let's say it's, somebody's had a hip replacement. We know they're going to have pain. It's expected. So we would want to give them pain medicines around the clock. And we also refer to it ATC, around the clock. But if that pain is kind of unpredictable, it's hard to dictate whether they're going to have pain or not. That's where you'll use that PRN frequency as needed. Okay. Side effects, we need to talk about side effects, particularly to opioids. They're the ones that have the most. We got to talk about constipation. So, we have to remember we have to watch for signs that may indicate this, severe constipation, which could lead to obstruction. So, abdominal distension, cramping, abdominal pain. Remember, opioids often cause nausea and with it, possibly vomiting. Sedation is another piece of this. Remember sedation, difficult to arouse, very sleepy. And one of the ones we always have to really monitor is respiratory depression. Remember opioids work on the central nervous system, okay? And so we always assess respiratory status when anybody's on an opioid, depth of respiration, respiratory rate, okay? Oxygen saturation is often monitored. Okay. People on opioids may become confused. Unfortunately, opioids tend to affect blood pressure, so they could be hypotensive, particularly orthostatic with position changes. Dizziness can go along with it, and urinary retention. So they're producing urine, but for some reason they cannot relax their urinary sphincter to actually void or feel the urge to void. And that covers pain. So let's go to the surgery chapter 17. So make sure you know all your types of surgery. Remember, diagnostic. Diagnostic is to make a diagnosis. Some example, often they will remove a sample of tissue to do this. So biopsy of skin lesion, biopsy of a lump in the breast tissue. Oftentimes, if it's more where they need to go more in further, they may do an exploratory laparotomy, using scopes through a small incision to do that diagnostic test or surgery. The next type of surgery is ablasive. Basically, it's a surgery that is performed to remove a diseased tissue. For example, appendectomy, cholecystectomy. Those are removing diseased tissue, to cure it. Okay. Palliative is the next type of surgery. So remember, palliative, exactly what it means it's comfort. So it's not trying to correct the problem. It's just trying to decrease or alleviate the symptoms or improve function. Reconstructive, or also referred to as restorative, is restoring function or structure due to damage or malfunctioning tissue. Okay. Then you have your procurement for transplant, and this is removal of organs for donation to somebody else as a transplant. Constructive surgery, this is to restore function lost because of congenital defects, so cleft palate, okay, and so on. And then you have your cosmetic, which is strictly an appearance. It has no medical purpose. In performing this surgery, it's usually more done when somebody is unhappy with the way they appear from a physical aspect. Know your variables related to affecting surgical outcomes. Age. As a general age is not really a factor in terms of surgical outcomes unless they are over 70 and frail or have some conditions that may impair surgical outcome, particularly cardiovascular disease, renal disease, and diabetes are the big ones. Okay, but it does not exclude them from having surgery. Often, generally, if these chronic conditions are well managed, the surgical complications can be reduced. Okay? Nutrition status is a big piece when we talk about variables. So remember, underweight or malnourished people, think about it. They're not getting the proper nutrition, so they're at risk for poor wound healing and increased risk for infection. Obese people are also at risk in terms of nutrition status. So usually their surgeries take longer. So the longer you're in surgery, the greater the risk for problems. And they tend to have issues with respiratory and wounds post-operatively. Okay. Fluid and electrolyte imbalances. Remember, those will play a big piece in this. They need to be well hydrated. So if they're dehydrated, that can often cause issues, as well as electrolyte imbalances, particularly potassium, because of its ability. Imbalances in potassium can play big factors on the heart's ability to function correctly. Medical diagnosis. So remember, the more chronic problems they have, the greater the risk for complications. And control of these chronic conditions can particularly be affected with surgery. Remember, we're stressing the body, we're causing trauma, and so they often will need kind of adjustment in their therapy beyond their normal treatment that they've been doing to manage them. So, ones that we really worry about in terms of outcomes: diabetes, COPD, so anything pulmonary related, asthma, somebody with obstructive sleep apnea. Okay, drugs play a big piece in this too as well, because they often interact with anesthetics. Okay, so it's really important that we know this. What they're taking, so over-the-counter drugs, herbal supplements, because they can interact. Particularly certain certain drugs will be held or modified before surgery. We talked about it may be held up to a week early, depending on the drug. So anticoagulants, your NSAIDs, aspirin, and then habits. So you remember smoking. Is a big one. So remember, increases the risk, smoking, people have more copious secretion, and so then they have more issues with respiratory and greater risk for those pulmonary complications because of it, as well as smoking impairs or delays slow wound healing because nicotine causes capillary constriction. Recreational drug use. Just remember when we talk about those recreational drugs, coke, methamphetamines, the drugs themselves kind of alter heart function, increases heart rate. And so, but the big piece here is that people who use these recreational drugs usually need higher doses of anesthetics to get the effect needed for surgery. Okay. The other piece here is we have to worry about withdrawal symptoms. We may see these withdrawal symptoms within an hour in the post-op period. Okay. Herbal supplements, we talked a lot about that. Just remember, a lot of them have interactions, particularly increased risk for bleeding. Garlic and caloba, and so on. Okay, so you always, and when a patient is taking any herbal supplements, always make sure you talk with the healthcare provider so you can give them instructions on when to stop it. And alcohol. Alcohol is, another one where it may require increased anesthetics as a result of kind of increased drug tolerance. And also we have to think about, you always think about, your alcoholics, your heavy drinkers, that they will often have some level of impairment in liver, liver damage. So that alters the ability of the liver to metabolize drugs. Okay. And also with liver disease, you have to include remember that one of the functions of the liver is clotting factors, and they may not be able to, the ability to produce those clotting factors may be diminished, and so they're more at risk for bleeding. Okay. So let's talk about, your preoperative assessment. Remember, height and weight. That's especially important for anesthetics, drug administration, dosaging. Vital signs is really important in terms of getting a baseline, because we'll use that post-operatively to kind of evaluate. You're assessing your skin turgor. You're looking at your thorax or your respiratory assessment, respiratory rate pattern, lung sound, assess your apical heart rate. Okay. Is it regular, irregular, and so on. You want to kind of assess all those things. Also remember that it includes, abdomen, also taking bowel sounds, and so on. But also remember, a part of the preoperative assessment is looking at lab tests. They're supposed to usually have a series of lab tests done just to make sure everything is okay. Make sure you know your values. So, that's your hemoglobin, hematocrit, your WBC, your platelets, your various electrolytes, your glucose. You need to make sure you know those, because those are things we are always looking at preoperatively to make sure they're ready to go. Okay. Remember, we talked quite a bit about prepping for surgery. Just remember, consent's a big piece of this. You need to make sure that the patient is alert and aware of what they're signing in terms of the consent. You have to, if there's unclear, they understand what the surgery is about or the procedure. You can ask them questions. If it still seems unclear that they understand what the procedure is about, then you go to you have to inform the surgeon, and they need to have a conversation with the patient before you can have them sign that consent. Remember, GI prep in terms of preoperative. Remember, there are 3 reasons for this: decreased contamination from fecal matter. Kind of decrease that post-operative distension, because remember, bowel function slows down or stops temporarily. And then it also helps kind of decrease the risk for constipation and straining post-operatively, because we kind of clean them out. Remember, they're going to be MPO, usually nothing to eat or drink after midnight, the night before surgery. Remember, if they have certain meds that it's really important that they take, which the surgeon will tell them which ones, they need to take it the morning of surgery with some sips of water, even though they're not supposed to have anything eat or drink. Just enough sips of water to get those medicines in. Remember, when we talk about anesthetics, they affect the central nervous system. You lose consciousness, sensation of pain, reflexes, and so on. Just remember that, anybody with anesthetics, they may also be given other drugs during surgery. That's your sedatives, your neuromuscular blocking agents. Remember, when we talk about neuromuscular blocking agents, they are paralytics. So they're basically paralyzing the patient during the surgery. So we always have to assess respiratory status, regardless of the drugs that are given, okay? But particularly neuromuscular blocking agents is a big one, okay? Postoperative complications, so shock, we talked about that, and that's usually related to bleeding or anesthetics. Hypoxia, remember the respiratory depression, that's our biggest concern in relationship to anesthesia. And it causes muscle weakness where we can impair respiratory status, okay? Other pieces to that is tongue can fall back and block the airway, and also spasms. Laryngeal or bronchospasms can occur. So we have to always be monitoring and assessing respiratory status. Injury, relationship to anesthetics and sedatives, usually level of consciousness is decreased, and so the ability to kind of self-protect is going to be diminished. Okay. If it's a regional anesthetic, they will have decreased or loss of sensation, because they can injure themselves and not realize it. And then when we get to post-op complications in terms of respiratory, they're at risk for pneumonia and atelectasis. Okay, and that's usually related to the various drug effects, creating shallow breathing, weakened respiratory muscles, and just immobility, not moving around. Okay. Remember, we talked about a couple of complications in relationship to wounds. So you have your dehiscence, that's where the surgical incision site just opens up, it's no longer closed. And the other one in terms of that wound is evisceration, where it opens up and internal organs are protruding through the wound. Okay. Now, if you ever remember, we talked about this. You're exposing internal organs, internal tissue with these types of wound complications, and so we need to be aware what to do. So you cover it with saline saturated sterile gauze and notify the physician, because they're probably going to have to go back in and reclose up that patient, that surgical site. Okay. Infection is the other wound complication we have to worry about. Okay. Remember, we're looking for those traditional signs, but remember, we have some things a lot of people think are infected, but they're normal in relationship to trauma, to the surgical trauma. So remember, redness is a sign of infection, but if it's just the immediate surgical area, that's okay, especially immediately post-op. We've caused some trauma, that's the body's response to that. Now, if it grows out, it's spreading, that'd be something to worry about. That's definitely a possible indication of infection. Fever, low-grade fever is often expected immediately post-op, so it's not necessarily a sign of infection. You have to kind of correlate this. Okay, and then remember, there's drainage. What should we expect? Okay, depending on the time period. Okay. GI disturbances. We talk a little bit about that. Remember, nausea and vomiting. Impaired peristalsis. Remember, paralytic ileus. That means the GI tract has actually stopped working. It's at a standstill. Usually, we see this a lot with abdominal surgeries, okay? And so we got to be careful in terms of when they start to eat. We need to make sure we assess for bowel sounds, okay? Bowel sounds is important in terms of making sure their GI tract is working, okay? Even if the doctor ordered a diet, you need to follow up on that. Make sure their bowel sounds present before they start. Urinary, urinary retention. Renal failure is another thing that can be a result of post-op surgical complications. So remember, kidneys are producing urine, but not able to empty out their bladder. That's urinary retention. Kidney failure means that they're not producing urine, and so as a result of that, they're not able to eliminate waste. So you always assess if somebody hasn't urinated in 6 to 8 hours. You always assess for urinary retention. First thing you do is just palpate the suprapubic area to see if the bladder is distended. The other thing in relationship to complications is thrombophlebitis. So basically that's inflammation of the veins in relationship to blood clots. So the most common one is deep vein thrombosis, DVTs, which is usually the result of immobility. Mm-hmm. But remember, our worry when we talk about these thrombophlebitis, these clots in themselves are a problem, but if they break off, they become an emboli. And so we worry about them going to the lungs is one of the main places. They can go to other places as well. We just have to remember that. So usually with pulmonary embolisms, they're going to all of a sudden have shortness of breath, dyspnea, and they will often have chest pain symptoms. Remember, we talked about, after surgery, they go to the post-anesthesia care unit, or we often shorthand say recovery. One of the key things you have to remember, in order for them to be released from the post-anesthesia care unit, respiratory status, circulatory status has to be functioning adequately, okay, independently. So we talked about, O2 saturation need to be at least 92%. Blood pressure must be kind of near baseline, heart rate, same thing. And the other thing is, because we're worried about aspiration, their gag reflex needs to be present. They need to be awake or easily arousable. Pain needs to be managed. Okay. And vital signs need to be stable. Let's talk about some specific things in terms of, manage acute pain. We talked about how to manage that. It's best around the clock, especially when it's post-surgical. We also need to talk about the different ways in which surgical sites heal. So you remember there's primary or first intention. That's where the surgeon has gone in and sutured the surgical edges of the wound are nice and approximate. They've sutured, sewed them together so that they heal. Then you have secondary. For various reasons, it might be left open. So your secondary intention is it's usually an infected wound, but it's been left open to heal from the bottom up. So, it'll kind of be open and granulated. Remember, that's baby tissue, fresh growth tissue will fill in that gap, okay? And that's secondary. Tertiary means that, it's usually done with really severe infection. Oftentimes they will leave it open, just the way this works, and then they'll go back and close it when they feel like it's been, the risk for infection is gone. Remember when we talk about surgical sites, oftentimes they may have some sort of drain to remove fluids from the surgical area. So, remember there's Penrose, which is like a stab drain, which just drains the gravity, kind of drains out. Oftentimes you just put gauze over the tubing and to soak up the drainage. And then remember we talked about two different types of drains that actually uses negative pressure to remove fluids from the surgical site. So you got your Hemovac and your Jackson Pratt drains. So remember, in order for that negative pressure to occur, we have to compress them. Okay, they have to be squeezed, closed in order for that negative pressure to work. Remember, as that negative pressure works and drainage fills up the container will kind of open up and deflate because the fluid's replacing that suction, that negative pressure. Also, the other thing we have to look at is in terms of what drainage would look like. Remember, we talked about, it starts off immediately post-op. It should, we expect it to be bright red, so that's sanguineous. Then it will become pinkish, and we can refer to that because it's a combination of kind of fluid and blood, serosanguinous. And then it progresses to a lighter color, and we often say it will get straw color, or serous, and then clear, okay? And at the same time, as these color changes occur, the amount of drainage should decrease. That's kind of the interventions. We talked about kind of assessment terms, intervention. But remember when we talk about infections that generally an infection signs and symptoms don't usually develop until the third or to fifth day after surgery. So if it's immediately after, it's not necessarily related to the surgery itself. It may have already been present, or it could be just the body's response to the surgical trauma. But we have to, assess we want to also decrease their risk for exposure post-operatively. So we always make sure we use aseptic technique when doing dressing changes. Impaired gas exchange, that's a big complication related to surgery. Oftentimes people who've had surgery don't want to take their deep breaths or take a deep enough breath, breathe very shallowly. So you want to make sure that we instruct them to cough. Deep breathing exercises are really important. Using the incentive spirometer. So remember, we wanna maintain clear breath sounds, because oftentimes if they develop, pneumonia, they're going to have adventitious breath sounds, usually a productive cough. Okay. And then, of course, this goes along the line with that pulmonary embolism we talked about earlier. So remember, we're looking for that tachycardia, that dyspnea. We will often see hemoptysis, which is coughing up blood. Okay. Urinary retention, we talked about that. So remember, we want them to void within 6 to 8 hours. If they don't void within 6 to 8 hours, then we want to kind of go the least evasive first. So have them try. Just sitting at the side of the bed if it's a gentleman. Go to a bedside commode if it's a woman. If that alone doesn't work, then use some sensory stimuli. Turn on the water. Awfully running water will often stimulate the urge, or put their hand in warm water. Kind of helps. Okay. If that doesn't work, then you have to go the evasive route. You'll have to catheterize the patient. And of course, remember, you need a doctor's order for that. Okay, that concludes the audio review for this quiz.